The newer generation of anticoagulants, commonly referred to as DOACs, that is direct oral anticoagulants, or NOACs, non-vitamin K oral anticoagulants, have largely replaced vitamin K antagonists like warfarin for most indications. This is due to their predictable pharmacokinetics, fixed dosing, and the fact that they do not require routine anticoagulation monitoring. They are classified into two main categories based on their mechanism of action. Direct thrombin inhibitors, that is factor 2A inhibitors. These agents bind directly to thrombin, blocking its interaction with substrates and preventing the conversion of fibrinogen to fibrin. Dabigatran, the only approved agent in this class. Because it has a high rate of renal clearance, approximately 80%, it requires careful dose adjustment and must be avoided in patients with severe renal impairment. Direct factor 10A inhibitors. These selectively inhibit factor 10A, the catalyst that sits at the convergence of the intrinsic and extrinsic coagulation pathways, preventing the generation of thrombin. Rivaroxaban, typically dosed once daily for most indications. It has high bioavailability, but higher doses, 15 mg and 20 mg, must be taken with food to ensure adequate absorption. Apixaban, dosed twice daily. It has lowest renal clearance, approximately 27%, among the DOACs, making it the preferred choice for patients with chronic kidney disease or end-stage renal disease. Edoxaban, dosed once daily. Uniquely, its efficacy is reduced in patients with supranormal renal function, that is creatinine clearance more than 95 ml per minute, which carries a black box warning for its use in atrial fibrillation. The FDA warning is based on the results of the phase 3 ENGAGE-AF TIMI 48 clinical trial. The study revealed that patients with non-valvular atrial fibrillation and a creatinine clearance more than 95 ml per minute had an increased rate of ischemic stroke when treated with 60 mg of edoxaban daily compared to those treated with warfarin. In these specific patients, clinical guidelines and the FDA mandate that an alternative anticoagulant should be used. Reversal agents. A major initial limitation of DOACs was the lack of antidotes for severe bleeding or emergency surgery. Specific reversal agents are now clinically available for most common drugs. Idarucizumab, a monoclonal antibody fragment that specifically binds and neutralizes dabigatran within minutes. Andixanet alpha, a recombinant modified factor 10A decoy protein that binds and neutralizes the activity of rivaroxaban and apixaban. On the horizon, factor 11A inhibitors. While not yet globally approved for broad clinical use, factor 11A inhibitors such as asundexian and milvexian represent next frontier in anticoagulation. Their mechanism aims to uncouple hemostasis from thrombosis, potentially preventing pathological clots like secondary strokes without increasing the risk of major bleeding. Asundexian recently received FDA priority review in May 2026 for secondary stroke prevention following the phase 3 Oceanic Stroke trial. The study demonstrated that adding 50 mg of asundexian daily to standard antiplatelet therapy significantly reduced the risk of recurrent ischemic strokes compared to placebo, notably without increasing the rate of major bleeding among patients with non-cardioembolic ischemic stroke or high-risk TIA.